Good morning, and thank you for joining today's webinar, Assessing County-Level Behavioral Health Systems with the Simple Scorecard. My name is Ronnie Smith, and I am a project coordinator at the Center for Behavioral Health and Justice, a community-based research center that provides local communities, organizations, and behavioral health and law enforcement agencies across Michigan with technical assistance, evaluation, and support to optimize diversion of individuals from jail and prison through the implementation of best and innovative practices at every intercept of the criminal justice continuum. Today's event will highlight the Simple Scorecard's development, significant findings, and potential to direct county-level strategic planning to improve behavioral health and justice systems. Before we get started, we have a few housekeeping items to touch on. First, audio-visual capabilities have been turned off for attendees to limit distractions throughout the presentation, but we do encourage you to ask questions of the presenters. You may enter your question in the Q&A box on your screen at any time. We will address questions as time permits during the Q&A portion of this event. If you are joining from a phone, please press *9 to raise your hand and ask your question during the Q&A portion. If you are interested in receiving continuing education credits for your participation in this event, please follow the link dropped in the chat box to confirm your attendance and participation. Shortly after the close of today's event, you will receive a post-event assessment via the email provided in your registration. The post-test must be completed to confirm your credits. Should you have any questions regarding CEs after the event, please contact Katie Alfonsi. Her email address will also be placed in the chat box. And lastly, upon the close of the event, we will distribute a copy of the PowerPoint presentation and a link to the video recording of this event and a document covering any questions we were unable to answer during the Q&A portion to all attendees. And now I'd like to take an opportunity to introduce our first speaker, Stephen Mays. Stephen Mays is the Diversion Administrator for the Behavioral Health and Developmental Disabilities Administration through the Michigan Department of Health and Human Services. Stephen was hired by Genesee Health System, formerly Genesee County Community Mental Health, in 1992, and for almost 22 years, he worked in a number of clinical positions, most recently as clinical liaison working specifically with law enforcement, hospitals, and the court system that designed and implemented Michigan's first adult mental health court. As diversion administrator with the Michigan Department of Health and Human Services, Stephen works as the liaison to the Governor's Mental Health Diversion Council and consults in devising and implementing strategic goals to help divert persons with mental illness from jails and into treatment on a statewide basis, and acts as a boundary spanner, connecting agencies across the state to assist with common goals and directives. Thank you. And Stephen, the floor is yours.
Thank you, Ronnie. And good morning, everyone. When I was first asked to give the opening remarks today, I thought it would be a good idea to give a little context to the origins of the Simple Scorecard. And for that, we need to go back in time a little bit. So in 2014, the Michigan Mental Health Diversion Council and the Department of Health and Human Services launched a jail diversion pilot program to address the overrepresentation of persons with mental illness and developmental disabilities in Michigan jails and in prisons. Ultimately, 8 pilot proposals were approved and funded by the Diversion Council in January of 2015, and those included Berry, Berrien, Kalamazoo, Kent, Marquette, Monroe, Oakland, and Wayne counties. And eventually we expanded to include Livingston and St. Joseph counties as well. These pilot programs continued to the advancement of jail diversion efforts across the state and helped the Center for Behavioral Health and Justice develop 4 key recommendations to the state to outline improved jail diversion strategies, including enhanced law enforcement trainings, standardized screenings at jail intake, the use of boundary spanners, and the implementation of warm handoffs out of the jails. Efforts of the Mental Health Diversion Council continue to advance jail diversion, intervention, and deflection throughout the state today, which includes the continued partnerships with the Center for Behavioral Health and Justice to provide communities technical support with the National Stepping Up program, statewide juvenile justice initiatives, a common statewide law enforcement and behavioral health training curriculum, and efforts to address the need for communities to engage in partnerships to bolster jail diversion efforts. Ultimately, the pilot program served as the backbone to the simple scorecard, and the data that was yielded from the evaluation of those pilots and initiatives, including the stepping up data, was used to develop the simple scorecard highlighted in today's webinar. I'm happy to get things kicked off today by introducing to you Dr. Erin Comartin and Mr. Leonard Swanson. First, Dr. Comartin joined the Wayne State University School of Social Work faculty in 2016 after leaving a 4-year faculty position at Oakland University. She received her PhD and MSW degrees from Wayne State University, and her research focuses on social welfare policies and interventions for vulnerable populations in the criminal legal system, specifically for individuals with behavioral health needs. She has conducted programs and systems evaluations of county level diversion programs since 2015 through funding from the Governor's Mental Health Diversion Council and the Department of Health and Human Services. And her recent publications can be found in Criminal Justice and Behavior, the American Journal of Public Health, and the Journal of Behavioral Health Services and Research. Mr. Swanson joined the jail diversion evaluation team in February of 2017 while completing his MSW at Wayne State University. His interest in macro social work led him to the confluence of the broken mental health and criminal justice system, which just became too convoluted and captivating to ignore. His skills in graphic information system technology and data visualization helped the team distill complex ideas to simple formats for interdisciplinary audiences of social workers, law enforcement officials, and legislative bodies. Leonard has presented his work at the Society for Social Work Research and the Michigan CIT Conference. So without further ado, I'd like to turn this over to my friend and colleague, Dr. Erin Comartin. Erin, the floor is yours.
Sorry about that. Thanks, Stephen, for that great introduction, and thanks for the years of collaboration that we have with you at MDHHS. So here at the Center for Behavioral Health and Justice, we envision helping communities use data and research to implement best practices to help those in our communities with behavioral health needs move out of the criminal justice system when possible. Next. We implement that vision by providing communities with expertise, evaluation, training, and technical assistance currently to 24 communities. And we do that by implementing innovative practices, collecting data to drive decision-making, helping communities create linkages to solve problems, and to develop plans and action goals moving forward. The current presentation, go back please, one slide. The current presentation includes data from the 15 counties listed here and numbered on the slide, but also you'll see grayed communities in the background of the map. Those are communities that we're currently working with, but their data is not included in this study, but we hope in the future they'll be added into our simple scorecard. Next. So the work that MDHHS and the Mental Health Diversion Council and the CBHJ have used to guide this work in this study is the Sequential Intercept Model. What this model is places and opportunities where an individual with behavioral health needs can be diverted from the criminal legal system and or towards treatment. And for the purposes of this presentation today, we break this up into two groups of intercepts. So at intercept 1 and 0 is considered pre-booking, with intercept 1 having opportunities before someone engages in the criminal legal system through dispatch or law enforcement. So this includes the crisis lines available and a crisis care continuum. Intercept 1 includes 911 dispatch and law enforcement interactions. In intercepts 2 through 5 are post-booking interventions. So this is when someone now has been detained at intercept 2, what happens during the initial booking process and the first court appearances. At intercept 3, you'll see that there are jails and courts. So this is after that initial period of booking and court appearances. What happens when someone stays in jail? What happens in the traditional court system, dispositional court, Or is there opportunities for specialty court programming like mental health courts or drug courts? Intercept 4 is after individuals leave detention, what does it look like upon reentry, especially around treatment engagement? So prison and jail reentry. Where Intercept 5 is what are the opportunities with probation and parole officers to help individuals with behavioral health needs not violate or return to the detention centers. But what we also know that there are these intercepts where we've created these factors we're going to talk about in a moment, but we also know that these are not siloed systems. And that in order to make this sequential intercept model really work, there's two overarching factors that help collaborate and coordinate across the entire system in one's community. And these two additional factors are leadership and expertise. Next slide. So like Stephen and Ronnie have said, the Simple Scorecard has come out of years of collaboration with our 10 pilot communities and our Stepping Up communities. And the scorecard is used to assess all those practices in the 5 intercepts and then leadership and expertise. Our preliminary findings show that it could be used as an evidence-based strategic planning tool at the community level, whether one is engaged with the Center for Behavioral Health Justice or not. There are 36 factors included in the Simple Scorecard, and we're going to get into each of these factors coming up. But just for examples, before I show you some data, an example is alternative law enforcement drop-off centers at Intercept 1 and evidence-based screening tools at Intercept 2. Next slide, please. So just before we get into the data, what you see here is how our communities scored on our factors. We present this to show you that there's quite a bit of variation in what these communities have implemented during their time that we've engaged with them here at the center. And what's interesting about the 36 factors that communities can use is that they can really make it based on what resources they already have access to in their communities, and they can adapt it for their particular needs. Now, I'm going to get into 2 slides coming up here about data analysis, but what we do want to point out is in our analyses, we controlled for median household income in the communities involved in this study, and we also controlled for if the community was rural or not rural. And we did this based on the literature and based on what we have found to be true in these communities, and that these are pretty important factors in rates of mental illness and substance use. And unfortunately, the communities cannot do much to change that. So we controlled for them in our models because we know they have an impact, but we know that those factors are not easily able to change or to be put into practice. Next slide. So one of the 2 key findings we have is one of the two key things we know communities care most about in working on diversion is that they really like to reduce the prevalence rates of mental health needs in jails. In 8 of our 10 pilot counties, we assessed their simple scores. So we ranked all of them on their 36 factors at 2 time points, in 2017 and in 2019. 2017 was baseline data just to see where these jails were at as they were setting out to implement multiple practices along the sequential intercept model. In 2019, in between those 2 periods, they had implemented found new funding and implemented new strategies. And then in 2019, we reassessed. And so what we did is we created change scores between those 2 time periods. So we took their pre-booking simple score change between 2017 and 2019, and then the prevalence of mental illness in the jails between 2017 and 2019. So for example, in County A, between 2017 and 2019, that county's pre-booking simple score changed and increased by 3 points. They implemented 3 new practices between those 2 time periods. And then we also saw a change score where their prevalence rate in the jail decreased 2%. So what we found by using a Pearson's correlation is that counties who improved their pre-booking simple scores booked fewer people with serious mental illness in the jail 2 years later. Next slide. Our second key outcome that we looked at is what type of treatment is being offered in the jails once someone's already booked. And we looked at this by what practices were the jails implementing in that post-booking period. So intercepts 2, 3, 4, and 5. And what you see on the graphic is a dot represents each county at their post-booking simple score and at the percent of the population in jail who have mental health needs who received treatment. And what we found in an OLS regression model is that a high post-booking simple score is correlated with a higher proportion of individuals receiving jail-based treatment. We ran quite a few other models to look at other outcomes that are significant regarding the Stepping Up initiative, but these were the two that we found to be most impactful. Where we gathered this data, I think, is a little bit important to talk about before Leonard and I talk about each factor that we looked at. Our team, our project coordinators in the Center for Behavioral Health and Justice, has spent many years building relationship with stakeholders along that sequential intercept in each of these counties. There's been monthly data collection calls and email exchanges. And so how we categorize these factors is through the years of experience with all of these stakeholders. Now I will turn it over to Leonard to start drilling down into our factors.
Hello, everyone. Really excited to get into each of the factors. We've got quite a lot of them, 36, as Erin, Dr. Cromartin mentioned earlier. So we're going to try to breeze through each of the points. We're going to give 1 minute per point, kind of like a lightning round, because there's a lot to go over. But I just want to thank all of the stakeholders that we've been meeting with over the last few years in developing these points. I see some of you in the participant list there. It's really exciting to see those names again. So let's get into it. Next slide. So we'll start out with funding. So if you found an outside grant to help support behavioral health and justice initiatives, you're probably going to have better outcomes. Some of these things are pretty hard to pay for, especially as people who enter jails, their Medicaid gets suspended, so you don't really have that funding stream to be able to offer services in a really crucial point, and it just kind of requires extra funding to find. So if a community was able to, get together a strategy to get funding, that proves you're already working together, and you probably threw some data in the grant application. Really shows a number of different things, but the funding helps. Next slide. So I should mention on each of these points, there's a few county examples. We have a criteria of how we awarded the point. We have a little bit of evidence in that kind of middle box, and then the kind of central question that drives it all. So these county examples, if you don't see your county name on there, it doesn't mean you're not doing this. We just try to pick 3 in rural, metro, urban. So, and we try to, give everyone a little credit for something here. So, look out for the county examples, but it doesn't mean you didn't get the point. This is a really similar point, county funding. If the sheriff's office or the county commission, funded a behavioral health position that kind of specializes in this criminal legal space, we awarded a point for that. There's, like I said, with funding streams, there's not all of this stuff is Medicaid reimbursable. So finding that a little extra money on here and there really helps. So we awarded a point for counties that really found that extra funding. Next slide. So some counties went so far as to request extra funding from their taxpayers. So this was typically done at a county level. So Jackson, Hillsdale, Washtenaw all did kind of mental health millages. Washtenaw had mental health and criminal justice millage to really support funding these kind of programs. Jail clinicians is one way to use those funds, but they're really flexible. Like you don't have as many strings attached, like through Medicaid or even grant funds, and they tend to go for quite a long period of time. So it allows you to be creative. There's still that need to show you've been using those dollars effectively to your county board. But counties that did pass a local millage were able to do quite a lot more. Next slide. So this is a bit of a trickier one. So CMH SUD, we mean community mental health substance use disorder. So how our serious mental illness and substance use disorder funding works, it's kind of in separate streams. And the way it kind of trickles down into the actual services rendered kind of on the ground level, sometimes there can be kind of a split of where you get your SUD services and where you get your mental illness services, where we know that people with kind of co-occurring, so with both substance use disorder and serious mental illness, that recidivism risk of coming back into jail is much higher. So we like to see, CMH organizations that have that SUD funding piece that they can bill Medicaid for kind of in-house. So there isn't this kind of coordination between agencies. We thought that was just a more streamlined approach, especially given the risk for criminal activity. So we were looking for whether the CMH, had that ability to get SUD services. Next slide. So assertive community treatment. So this is a pretty common program in community mental health organizations. It's a pretty high level of service if you're not already familiar for folks that have really high needs. So this is almost a daily intervention with a whole team of folks that really are able to offer supportive services. Folks that have ACT programming is what we call frequently come in contact with the criminal justice system, and it's just a high level of need. So if we knew this kind of program was out in the community, it's a good thing. So I know there's forensic assertive community treatment teams. We weren't able to verify whether all of our counties had those or not. So we stuck with the ACT teams for purposes at this point. So next slide. So that was all Intercept 0 and talking about kind of community services, what's going on kind of before any crisis occurs. This is where we'll talk about Intercept 1, where law enforcement. So next slide. So police training is a huge thing. There's a lot kind of going on in this space. There's a lot of evidence-based models that we like to see. CIT, Crisis Intervention Team, is the most predominant model with the most kind of research behind it. It's meant for a kind of a specialized group of officers, 40-hour training. It's quite a lot. So we're looking at around 20% figure of officers in the county getting that kind of training. And then these other models, managing mental health crisis, Michigan Crisis Intervention System, and mental health first aid, kind of shorter training models. So 8 hours or 16 hours of training, and which is kind of meant for a wider audience, really to kind of get your feet wet in the whole training game. So to be perfectly honest, we don't have a list of every officer in the state and how many have gotten that training, but we had a good idea whether a county was doing substantial training efforts in their area. And when we saw that, we'd be awarded a point. Next slide. So the training on its own is one thing, but then actually recognizing an incident as a mental health incident, we thought was really important. So a good way that we found to kind of define that was whether the law enforcement agencies had a mental health code. So, there's lots of different codes and categories that law enforcement use for these kind of incidents. Could be welfare check, could be, domestic incident, could be, domestic disturbance. But when using that mental health code signals to us that you recognize that there's something else going on that's affecting their behavior, right? So using that code, more than just your kind of 2 or 3 times a year, over 1% was generally what we're looking for. And again, it's not like we had all of the law enforcement data for all of the agencies that we're working with, but if we generally knew this code was being used, it can help you do a number of things, which we'll kind of get to in these next slides. So next one. So if officers start to code these incidents, you can start to do something with it. So referrals to treatment. So some of our counties, so we're highlighting Monroe, Oakland, Washtenaw here, but also Muskegon's really been doing this lately, and Calhoun for some time. When an officer notices a mental health incident, they send this report. Erin's been doing this really well too, where the CMH can kind of follow up and do some kind of care coordination. Because what typically happens in a 911 call, let's say it's a suicidal incident, law enforcement shows up, brings someone to the hospital, they may stay or may not, and then kind of get discharged. That there's no obvious place that the public mental health agency knows what happened. So these referrals are a really key linkage point that we like to see, and we awarded a point for it. Next slide. So this kind of piggybacks off that training initiative. So is dispatch kind of in the loop of which officers receive some mental health training? So, if you have your specialty team of officers, particularly CIT ones that are really kind of meant for this work that really volunteer and love that, particularly attuned to these kind of incidents, if say there's a mental health crisis in the area and dispatch doesn't know which officers to send, you might not be maximizing the efficiency of doing that training. So some dispatchers have a list of like who your active CIT officers are or your kind of other mental health training officers are. and can send them to the appropriate scenes. We thought that was a really great practice. I mean, we like to see that pop up in other places too. Next slide. So co-responder model, there's a lot more chatter about alternative ways of approaching crises. So this is one model that we've heard about across the state. Another one, Cahoots and the STAR out of Denver and Colorado and Eugene, Oregon. We haven't really seen that pop up in Michigan so far. But these co-response units, by that I mean a clinician and a cop riding together in a vehicle, either attending live crises or following up on crises after they happened, just to kind of meet with a person, maybe debrief and see if there's something else that can be done. So if we heard this kind of ride along situation, we would award a point for that. Just in general, it's harder. It can be harder for law enforcement officers to build that rapport. I mean, that uniform carries a lot of honor, but it also carries a lot of stigma for folks that don't want to get arrested or fear persecution. So it can be easier for that clinician on scene to build rapport and de-escalate the situation. Next slide. So alternative drop-off. This is another program we don't see a whole lot of times, but Oakland, for example, and the Jackson Marquette have some setups too. So we were looking for some place other than the emergency department that law enforcement could use as a drop-off location when they have people experiencing mental health crises. And so why that's important is if it goes, so these places are typically operated by the public mental health system or their providers. So they typically can connect with longer ongoing treatment at a lower cost for the consumer. Now these places can be quite expensive to build out to get implemented, but once they're going, they can be a viable alternative for law enforcement to bring someone to. Next slide. I think I'll pass it back to Dr. Martin here.
Thanks, Leonard. So from here on out, we're going to be talking about the post-booking factors that I showed you earlier in the data. But there are 4 innovations that communities can do at Intercept 2. The first, next slide, please, is evidence-based screening tools. So did the jail use an empirically validated screening instrument to identify and refer people during the booking process? So what we know is that corrections staff are not trained in mental health. They are trained to do corrections. And so they may be able to identify someone in having a serious mental health crisis, but oftentimes mental health symptoms are under the radar and not easily seen, especially to an untrained eye. So what we gave a point for is if the jail used an objective and validated screening tool as individuals were booking into the jail. So the 2 most common for mental health that have been validated in jails is the Kessler-6, shortened to the K6, or the BJMHS, which is the Brief Jail Mental Health Screen. And some of our communities that have embedded that at booking for everyone coming in is Monroe, St. Joe, and Washtenaw. The other tool that we have listed here is the RODS, which is an opioid dependence screen, a short tool that can be used specifically for opioid use. What is key about having that evidence-based screening tool too is not that it's just there, but that it's actually scored and it's actionable so that it is used to actually refer someone into treatment in the jail and services in the jail or once they leave. Next slide. So diversion. Did the county have a program designed to divert pretrial detainees who showed signs of mental illness? What we know through our research and what is known in the research literature is that individuals with mental illness stay in jail significantly longer than individuals without mental illness. And that is even once you consider someone's offense. Even controlling for that, individuals stay longer. And we know that if individuals stay in detention, that they can decompensate and their symptoms can get worse. So a key goal in some of our communities, and we hope in all of our communities going forward, is how do we get individuals with mental health needs out of jail earlier when it's appropriate? Next slide. So the next is the jail and CMH having data matching practices implemented in the jails. So this is a coordinated system where CMH workers are notified when either one of their clients goes into the jail or is coming out of the jail. In some of our communities, this is an automated process where booking and release reports are sent to the CMH system, so they are notified. Sometimes it's a hand-eye match, but having this notification can really help people get the connection to care as they're going in and out, make sure their medications are stabilized and that they can stay in treatment without that time in jail kind of destabilizing their mental health symptoms. Next slide. Did the jail have regularly scheduled interdisciplinary meetings between the behavioral health clinicians and the criminal justice staff for case coordination? So this is where there are consistent ongoing meetings where individuals who have behavioral health needs in the jail are discussed to both make sure they're getting the care they need, that they're ready to be released from the jail with what they might need, such as medications or prescriptions, but that there's this cross-systems communication, thinking about how individuals can have their needs met. We have good examples of this in Berrien, Marquette, and Monroe, others as well. Next slide. So now we're moving on to Intercept 3, which is the jails and the courts. And here we have 7 practices to discuss, so more so than the others. Next slide. So what we found to be a helpful practice in jails at Intercept 3 is if there is a dedicated clinician where the jail is their primary place of work. So we know that there's a federal policy that says that Medicaid is not billable for someone who is detained. It's called the prisoner exclusionary policy. So lots of our CMHs are funded through Medicaid. And so having a clinician in the jail is not an easily refundable service. But when communities make a priority to have a clinician there, they're often doing that on general fund dollars, grant funded dollars, millage dollars, which means they've made it a priority to engage with individuals who have mental health needs in their communities while they're detained. And we see lots of examples of this. And we could have given a point if someone was there 40 hours, or even if there was in our more rural communities where 40 hours just isn't feasible, 12 hours per week, but that their primary responsibility was to be in the jail. Next slide. So again, as Leonard said, a key component of addressing mental health needs and prevalence in the jail is the co-occurring status of individuals. We know that individuals who have co-occurring behavioral health needs are more likely to come in and out of the jail. So addressing substance abuse needs is equally as important with mental health needs if you want to reduce that revolving door in and out of the jail for this population. So we gave points to jails if they offered substance use disorder therapeutic services in the facility. And examples that do that really well are Barry, Genesee, and Kent. Next slide. Kind of continuing that idea about providing substance use disorder treatment services was also about medications for opioid use disorder. And on this slide, we're particularly talking about continuation. Given the opioid epidemic and how withdrawal in the jail could be detrimental to someone's health, we gave points to communities that were offering either methadone or buprenorphine in the jail if someone came in with a prescription. And it had to be to the entire population who need it to get a point for this, not just for pregnant women. Next slide. We also gave a point if the jail was open and willing to provide inductions for MOUD. So if in the last slide, it was about were they continuing if someone came in with a prescription for that medication. In this case, is if somebody needed it upon jail entrance without a prescription, was that jail willing to start the medication while the individual was there? Next slide. So the next is specialty court. We're out of the jail now and onto the court system. Did the county have a specialty court other than a drug court or sobriety court? We know that every community in the state has drug courts. And so what we wanted to know is, was the community doing more around mental health courts, veterans courts, where a key component of that specialty court is mental health? So counties were given a point if there were more than a drug or sobriety court. And we know through lots of years of research, some of our own, some of our colleagues across the nation, that drug courts are really effective, particularly for those who stay in the court and are successfully complete it. There are lots of key outcomes showing that their recidivism rates go down, their engagement in treatment goes up, and it's a really useful tool. Or program. But the unfortunate part is that there's more need than specialty courts can provide. So increasing more types of mental health or substance use or veterans courts is going to be key, a key diversionary tool going forward. Next slide. So low circuit court to prison was our next practice that we looked at. We're under 20% of circuit court dispositions sent to prison. And we use this as a kind of a proxy for a tough on crime approach to sentencing in each community. So how often were people being sent to prison from the jail or from the courts in that community? So they were communities received a point if it was under 20%. Next slide. The last factor at Intercept 2 is if the county had a not-for-profit provider for jail behavioral health programming. So some of our research has shown that when it is a nonprofit provider, either the CMH itself or one of their contracted nonprofit providers are in the jail providing behavioral health, individuals are more likely to be screened, referred, and served in the jail for their mental health needs. Conversely, counties that contract to for-profit providers for this behavioral health programming saw significantly reduced service provision to individuals with mental health needs. So now I will turn it over to Leonard for Intercept 4.
Hello again, everyone. So Intercept 4, we're talking about reentry to the community. So this Intercept broadly talks about returning from jail or prison. We're going to focus on jails today, mainly because it's a lot of where our work has been focused on the point of jails, but also since people with serious mental illness are really in that kind of churn of coming in and out of jail quite often, which is kind of we envision as a point of Intercept to bring people toward behavioral health treatment. So next slide. So the first point we have here is around data sharing issues. And really this point could probably be appropriate in a number of different intercepts. But we put it here because that coordination between in-jail service and post-jail service is really key. And so something that can get in the way is are people understanding of HIPAA and 42 CFR Part 2, which are the complicated laws that really deal with when you can share private health information, specifically mental health information. So people tend to err on the side of caution in not sharing information. I mean, it's good to protect confidentiality, but it can really hurt continuity of care, especially at that point of release. So if we heard that these laws were being a barrier to care coordination, we didn't award a point for that. Next slide. So release time, this is a kind of a tricky point as well. So for this point, we're only looking at time served releases. Like if someone bonds out, when they were able to post bail, or if a judge makes an immediate decision on pretrial status, we weren't looking at that so much because that can happen kind of at any time. But for time served releases, some jails said, all right, your sentence ends, May 27th at midnight, you get released at 12:01. Whereas some jails are like, I think the morning is a more appropriate release time. And when we saw that the release times were in the morning, like 5 a.m. or later, we awarded a point for that because, it's not many too good things happen in the middle of the night. And mental health and substance use agencies tend to be open during daytime hours. So we think it would be better for continuity of care that these releases happen in the morning. Next slide. So psychotropic medications. So when you're in jail and you're on some psychotropic medications, being able to continue those medications can be pretty important. So whether that's you get a supply of those psychotropic meds that you were on, and you can physically take the medications with you to wherever it is you're going, or if you receive a prescription from the jail medical department to then pick up your meds at a different place. we were awarded points for that. So we didn't count it if someone brought in their own meds and then took their own meds with them upon release. This was if we notice a particular policy where the jail was really looking out for those, that's continuity of care with medications. Next slide. Discharge planning. So when working in the jail, people can leave at any time. I don't mean just like walking out the door on their own, but sometimes it's sudden decisions based on someone shows up with bail money, or the judge you get an appointment at arraignment and when they're free to go. So it's really unpredictable when people leave jail, and that makes it really difficult to plan for that release into the community. So we awarded a point when we saw jail clinicians, incorporate discharge planning as the standard practice, even on the first time that you see someone. Jail clinicians, if they know the charge information, they kind of have a sense of how long someone's going to stay, but sometimes they don't. So having that conversation kind of early on really helps lay the groundwork for what the plan is upon release, because some folks kind of need that extra thinking through to connect with the next steps there. So next slide. Medicaid reactivation. This is a high bar, admittedly. Only one county that we know of has really figured this out. So we talked a little bit earlier about how your Medicaid is suspended when you're booked into jail. So what happens when you leave? It's not automatically activated. So one county jail worked out with their local Department of Health and Human Services, where they just send booking and release forms every day to kind of keep track who's in, who's out, and Medicaid status there. So that's the only place that we know of where upon release, there's some process to turn that Medicaid back on, which we thought was a fantastic practice. I know some jails might not want to look at it too deeply, because it's not all the time automatic when someone's booked into jail. Sometimes there's a lag of a few days, so it can be convenient not to look too deeply. But we really like this approach. So on release, then folks can really engage with services in the community afterwards. Next slide. So community corrections, and by this we mean kind of probation or parole. So we got a couple points here. Next slide. So specialty probation. So, in a lot of our jails, we see folks booked in for technical violations. So some violations are actually severe, like they committed another crime and they kind of have to go back to jail for that other crime. But sometimes they're just violations like showing up or, failure to appear. And so these kind of behaviors might not be interpreted as mental health concerns if there isn't kind of this attention given to mental health needs. So, some probation offices have specialty probation officers that really attend to this population, which can kind of inform, whether that decision to violate or not, and just kind of be aware of the mental health concerns in that sentencing requirement. So we awarded a point when we saw a specialty probation program. Next slide. And so when probation had a good collaboration with the community mental health agency in general, we awarded a point for that. We left it pretty broad here. So we frequent interactions, formal interdisciplinary program, regularly scheduled meeting, referral system. There's a lot of gray area around what that relationship can look like. But in general, if we could tell they were really on the same page, we awarded a point. And why that's necessary is, some people might make it through the whole criminal legal system from law enforcement to jail to courts to release before mental health symptoms are really picked up on. Maybe it was lack of screening instrument, maybe that someone's kind of can keep them symptoms to themselves, but then something might show up at the probation or parole where the officer can tell something's going on. If they have that contact with the CMH, then they can really incorporate that case planning into their supervision. So one example we like to talk about from Kalamazoo is that we have a CMH person really assigned to probation and assigned to parole, where they're actually showing up every week and saying, hey, are there folks where we can talk about and link up with services if needed. So we think that's a great practice to kind of serve as that fifth intercept to notice things are going on. Slide. Right, so now we're into the leadership and expertise categories. So these kind of span across all of the intercepts, where if you're kind of doing some of these things well, you're really going to see impact kind of across the board. So our first one here is, do you have a champion? So we define a champion as someone who can move a project along kind of regardless of who you work for. So, if kind of everyone stayed in their silo and did their own job and like did it well, we would still have these system problems that require working together. So it usually takes, we found, a leader to really push the envelope for everyone in their community, moving people all along. So we call those folks a champion, usually at the executive or leadership level or kind of managerial level, that can really push the agenda in a given county to pay attention to behavioral health and justice concerns. Next slide. So resistance to change, this was a tricky one. So again, I mean, if folks kind of do their own job and say, this is kind of how we've done it, this is how we're going to do it because it's worked so far, and aren't really receptive to new kinds of programs or even data collection to show whether something's working or not, we didn't award a point if we saw some resistance going on. So sometimes that looks in the form of hey, let's look at how effective what you're doing is, and they're like, no, we're good. We have enough on our plate. We got to keep going. We really like that openness to new ideas and innovation because the world's a shifting landscape, and we got to kind of stay on top of what evidence-based and research is showing. So we awarded a point if we didn't encounter these roadblocks. Next slide. Strategic planning. So some counties make a point to get together of kind of gathering the key stakeholders across different areas, whether that's the jail, the law enforcement, the mental health system, the courts, to really get a community plan, because the issues might look different in, say, a Washtenaw County than they might in a Muskegon County, and they need kind of different activities going on, and then they kind of need everyone else on board. So really thinking about where you're headed as a county in a regular way. We call it sometimes they're called diversion councils, sometimes they're called kind of advisory committees. But in general, if we saw that working together at a leadership level, we awarded a point for strategic planning. Next slide. So measuring own outcomes. So this is kind of what we do a lot as a center. I mean, we can kind of come in and work and really get to what data is going on. But we thought there's like an extra level of sophistication that we wanted to award, because if you're able to do some of that work of, seeing how many people are entering the jail with serious mental illness, how long they're staying, how often they're coming back, and how often they're connected to treatment. Like if a county was able to kind of get to those things on their own, which can be pretty tricky, we awarded a point for that. Because it requires like merging of data and then thinking about like, okay, what is it we want to go and where is it we want to change? So without those kind of pieces in place on your own, it can be difficult to kind of measure your progress. So if a county was able to get to some of these metrics on their own without our help, we awarded a point for that. It requires quite a bit of expertise that can be helpful. Next slide. So networking. So how well was a county or key county stakeholders connected to other ones in the state or even the country, really? So we kind of do this intentionally in some of our recent projects. We call them communities of practice, where we try to bring folks from different counties together, kind of working on similar problems to share lessons learned and barriers and kind of working through them, really to know, kind of bring new ideas to your county and really implement them. Or think about new ways of approaching barriers. So, if we knew that a county was like kind of already knew the people at their level in other counties that really could bring new ideas back to their home territory and really implement them, we awarded a point for that. Whereas if you kind of stay in your own county and just kind of work with, the people within it, you're not really going to hear the best ideas that kind of come out because these systems look so differently across the state and the country. So we awarded a point if you knew some other folks. Next slide. So evaluation experience, admittedly, you get a point for working for us, working with us, I should say. So why we think this is important is when you get some academic work in this space, behavioral health and justice space, then we kind of do some mapping to see how your system is really working. We bring some evidence-based practices to say, hey, this is going on in the research, or hey, this is what other counties are doing. And it kind of gives you opportunities to step up the game a little bit and really show what's working and what's not. Really where your successes are, where your barriers are, and it really kind of lets you shine inward of what's happening. So we awarded a point if you've kind of gone through that experience of seeing what's working, what's not, where you can improve, and in evaluation organizations we think are effective in that way. Next slide. Boundary spanner. So this is again another point that can really apply to all of the intercepts. But if you had, we call it champion with boots on the ground. So someone who works with multiple systems, whether that's the jail, the mental health system, but also multiple intercepts. So, maybe it's probation, intercept 5, or maybe it's law enforcement, intercept 1. Someone with mental health concerns is going to kind of flow through all the intercepts. And they might need advocacy work at a lot of these different stages. So having a boundary spanner, typically run by the CMH or a provider organization that really had, feelers out to all these different areas that can kind of flow in between the systems, not only between institutions, but the intercepts. We awarded a point for that because a lot of this kind of needs flexible and just knowledge of how these different institutions work and how they operate. And the criminal legal system and the mental health system on their own are pretty complex. So having one person who's kind of a local expert that can really advocate for clients is kind of the key difference we had between champion and boundary spanner. Kind of boots on the ground level. We awarded a point if we saw that kind of role in the county. Next slide. So now we're back to our control variables. Dr. Kerman mentioned earlier, these are things that didn't count towards or against the simple score, but made life harder if you didn't have these things. So like median household income, if the county didn't have a lot of money flowing through it, it's just a tougher time, right? I mean, there's so many things that correlate with poverty is, experiencing trauma, and there's mental illness, and then substance use concern, and there's housing and recidivism. All these kind of things just make it difficult for counties that just have a poorer population. So this is one of the things we checked against, like, is it simple scorecard really working, or is it just kind of showing what's happening in richer counties? And so we were able to, our findings are kind of controlling for whether a county had some money. Next slide. And so the other kind of control variable that Dr. Kumar mentioned earlier that I'll reiterate was the county rule. It's harder to do these kind of practices if you're in a rural space. And by that, I mean, if you have a rural mental health system, you don't have the kind of scale to implement some of the programs that, say, Kent County or Wayne County or Macomb County can do. So if you only have so much funding available, you can't, implement it's harder to implement a whole new crisis drop-off center, for example, right? I mean, the scale is one thing, and it's just kind of difficult to implement other things. I mean, transportation is another issue, like in rural counties in particular. So if you don't kind of have that public infrastructure, it's harder to move things forward there. So next slide. Right, we made it through all of the points. I hope some of you are still with us in our whole journey through 36 simple scorecard points and the 2 control variables. So we're, as a wrap up here, this is kind of what we found across all the intercepts. We really think this could be a viable strategic planning tool. So, folks on the call, I know are involved in some of these counties that really play those champion and boundary spanner roles. And we have a list of things that work, and we have some findings that tie the list to some good outcomes. So like if you're doing well on intercept 0 and 1, we think there's a connection to the number of people walking in the door with the jail door with serious mental illness. If you're doing well at intercepts 2 through 5, we think we have some findings suggesting that you're probably going to do better at connecting people to treatment. So using this scorecard, we envision could really help direct and inform that strategic planning at a county level. And the next point is no county received a perfect score. I mean, it was about 40 slides ago, but Dr. Carmartin had that big chart of all the different counties and how many check marks they had. I think the lowest score was around 7 and the highest score was around 25. So every county has some room for improvement here, which is actually pretty exciting. I mean, that gives us a lot of space to really push the envelope and really improve outcomes, we think. So I wouldn't get too down if you see a lot of gaps, and I wouldn't get too proud of yourself if you think you got a lot of things going on. I mean, there's a lot to do here, and we like to kind of push people and give a little incentive to kind of push the envelope and make systems better. So keep at it. But I mean, these practices are hard to implement. Like, remember we looked at the 2-year period, one in 2017 and one in 2019, and some counties made a 2 or 3 point change. I mean, it takes about a year to do these points. It's a lot of work. I mean, it's not easy to just get a perfect score, next year or even 5 years from now. So, and none of these single practices or policies is really going to move the needle on its own. I think our kind of big takeaway here is that all of these practices kind of work best together. Like if you take law enforcement, for example, if you're doing the training, which is awesome, you should do the training, but then also recognizing the calls, referring them to treatment, thinking about where they're going afterwards, getting dispatch involved to make sure you're maximizing that training. All of these other components really play off each other well and can improve the whole system. So I would ask folks to not just look at a single policy and practice and say, hey, we do this really well, but really expand that scope of what we're trying to do, because we think they work better together. So innovative practices and policies work in tandem with others. So we think that there's a lot of synergy between the different intercepts and between these different practices that really make the system better. And the last point I'll make, which is not written here, but we don't think this is a final product. We definitely think there's room for improvement here. This is our first shot at getting a simple scorecard together where we're just combining all of the policies and practices. And this point is on your CEU test, so bring it home lightly. Our findings come from our interviews with stakeholders and just meetings and calls. And so we love the feedback from you of, this makes sense or this doesn't make sense. If you got qualms about your particular score, we can talk about it, but this still got us to go through peer review. But we really think we're onto something in terms of the combination of different practices. And we love feedback and questions that can come out of that. So I think that's my soapbox, Ronnie, and I think you're willing to take us to the next piece.
Sure. Thanks, Leonard. And excuse me. And thank you, Dr. Comartin. At this time, we've reached the Q&A portion of the event, and we've received some really great questions throughout the course of the presentation. But if any additional questions should arise as we go through this portion, please note them in the Q&A box and we'll address as many as we can. So I'm just going to get started with the questions. So the first one is, for those counties where the police departments use mental health codes, were those sole mental health codes, or were they able to utilize multiple codes to identify, for example? And so an example, domestic violence, but it was also a combination with a mental health concern.
Yeah, that's a great question. We would love it if departments had this kind of multiple code options, like if it was a domestic violence situation and a mental health code, that would be fantastic. But typically what we see, and this could vary department by department, is you kind of just get one category for it. So, it can be tricky to call something only a mental health incident. So recognize the kind of tension there. But, if the departments were able to get multiple codes and there's some way to at least pick out where the mental health incidents are, we would definitely award a point for that.
Thank you. The next question is, how responsive were sheriff's offices in answering these questions? Was there any way to independently verify a county's response?
Yeah, so I can talk about this a little bit. So the way we learned whether a county was getting a point, we didn't really have a survey that went out and just kind of trusted them. These are understandings of how these counties were operating, came from about 3 to 5 years of working with them on different projects. So these were our own kind of judgments as project coordinators, working with the counties. In some cases we would ask directly, like, do you have an ACT program? Yes or no? I mean, that's pretty straightforward. But, a lot of our impressions, like how well they were connected with other counties, that was kind of a judgment call left up to the coordinators. So, that was kind of our check on whether, folks would be quote unquote honest in telling us about their score.
Okay. And next was, have you or would you consider adding implementation of an AOT program to get a point in Intercept 0?
Yeah, I think that's fantastic. And it sounds like a Judge Milton Mack question.
It was.
Yeah, I know he's a great champion for the AOT. One of the tensions that kind of touches on is we kind of limited to things that we know we could score. So it's very possible that AOT programs were in all or some of our counties. We just at this point we don't have a good way of knowing where good AOT programs are. So I think that would be a fantastic point to add here. And I think there's a number of other fantastic points we could, and I would love to add here, like, how many misdemeanors do you book, or how many people enter the jail with technical violations. But sometimes it kind of comes down to what data we have. But and I would love your thoughts on how we could look at that at a different county level to see whether folks have good AOT programs going, because I think. And for folks who don't know much about AOT, assisted outpatient treatment, there's some really good evidence coming out of Kevin's Law and some other similar laws across the country that help move people into treatment when there's smoke before there's fire. I mean, if folks kind of recognize mental health issues going on, that ability to compel someone into treatment has shown some pretty good outcomes in linking with care, before kind of the crisis goes on. So that would be a really good spot for Intercept 0. It's just a question of how do we measure it.
Thanks, Leonard. The next question is, how receptive have the counties been in receiving the simple score? And what stakeholders in those counties received the score?
Yeah, so we picked out some kind of key stakeholders that we've been working with on our jail diversion and stepping up projects that really move the needle forward, kind of like our champions there. And generally those stakeholders are open to our impressions of them. So, if people are begrudging us, we haven't heard it directly yet. There's probably some, oh, Leonard, why didn't give us a point for this? I get that, and it's probably going on, and that's fine. We like to, challenge our sites and really encourage them to push the needle forward. But in general, we've also heard the positive reception of, hey, this is finally a way we like a score, yes or no. It's simple. Like, are you doing it or are you not? So it really appeals to, especially our law enforcement partners that really like that concrete, hey, we got to get this done method, which has some merit. So, we encourage that, harsh mirror at times.
The next question is, are there any efforts to have all jails use the same intake questions during the booking process that has these assessments embedded in them?
I can take this one. Early on in the process, this was really one of our goals at the CBHJ, is to have jails using these screening tools. And some of our champions that have gone on to be in the legislature have actually proposed bills to make this standard. So there are, state level policies moving forward. It's not that we're suggesting the exact screening instrument, but just that there is a validated screening instrument. So the ones, again, that we recommend for mental health are the Kessler 6 and the BJMHS. But we're not, in our recommendations to the legislature, it's not necessarily one that is going to be the silver bullet. It's that there is an objective screening tool. So there are key efforts statewide going on, which is great news.
Thank you. The next question is, what effect might the state's plan to privatize the mental health system have on those individuals in jails with mental health needs?
Yeah, so I can talk about this a little bit. We do have some findings that in jail, it was one of our points of nonprofit mental health providers. So when we noticed that there was kind of a for-profit system, whether that's most jails, medical systems are private entities. But if that private entity was also doing the mental health needs in the jail, then less folks were being seen in general. So it's a bit different, since the privatization of the mental health system in general is about community services I don't think like your Horizons or your WellPaths of the world are going to kind of step out and do these community services. So it's not, exactly a fair comparison. But in general, when we see this conflict between the private providers in a system and a non-for-profit provider in the jail system, at least, we noticed that the nonprofit public providers saw more people. So, it's kind of unclear how the whole privatization is going to shake out exactly. So it's hard for me to really comment on what it's exactly look like. But at least in the context of the jail, we did notice a significant difference.
Thank you. Next is, how were the HIPAA barriers addressed? And can you provide some examples?
Yeah, how were HIPAA barriers addressed? So HIPAA rears its head in so many different places in this space, right? Because we're talking about a lot of different organizations working together to really attend to the same kinds of folks, or literally attend to the same folks. So like one of the terms we use is high utilizers or frequent flyers or familiar faces. This is means a person that interacts a lot with law enforcement. They might call dispatch, 500 times a year or something. They might show up in jail quite a bit. And so kind of everyone knows kind of who these folks are. And so knowing what's legally in bounds to share information for care coordination is important, because under HIPAA, you can share information under care coordination. So at least one concrete example I can give, it doesn't exactly lend itself to the serious mental illness world, but one area we found that can really be helpful in working through these problems is for overdose care. So we've been working with EMS agencies and community mental health agencies to establish kind of post-overdose response programs. So when an EMS agency, reverses an overdose, for example, they can legally, under one lawyer's opinion, pass that information on to either a CMH or a provider organization to do follow-up work. And you don't necessarily need to collect that patient consent while on the scene, at least according to the EMS lawyer's opinion and their reading on HIPAA and Michigan Mental Health Code. They're not subject to 42 CFR because, they're not a behavioral health organization. EMS agencies aren't, but they can still forward that patient information under continuity of care. And because that person is at a high risk for, decompensation and subsequent overdose and death. So I know it doesn't seem like a lot of folks err on that side of caution. It's like, oh no, it's my overdose information. I can't share with anyone. It's private. And I understand that, but there are ways to work through the law that allow this care continuity that really make a huge difference. Because when those folks started getting kind of follow-up services in care, almost half of those direct contacts said, yeah, I'm up for another appointment. I could really use the help. So, that's just kind of one example of how care coordination, you can work through the legal piece, but it takes tricky and tricky navigation through the existing laws.
Okay. And next is, do you have any sense if the pandemic has impacted simple scores? If so, how?
Fantastic. I might pass this on to Dr. Martin. I'm talking a lot, and I know she's working on a study about pandemics.
Thanks, Leonard. You can also say quite a bit, I'm sure. But what we know briefly is that we have looked at data in three of our counties now, where we've been collecting data over the course of the pandemic. And in two of those communities, we do know that the individuals booking into jails, the proportion booking in with mental health has gone up significantly. So at least in that first period, we've looked at right in the spring of last year into the summer, and that first spring period was significantly higher with a return to normal in the summer. So we do know that the outcomes are changing slightly. To talk about, thinking about all these 36 factors, and the more it seems like we'll be adding based on great information here, is that we know that so much shut down last year. And so the ability for communities to continue some of these factors did stall, but have since, picked back up again, like thinking about the clinicians that go into the jail as their role. I mean, that was not allowed in most of our communities at the beginning of the pandemic because no one knew if it was safe. But most of that has returned to normal might be unique and different and in different ways, but things are happening, like the implementation of telehealth. Using telehealth in and out of the jail with these clinicians has been a big step in the right direction. So while our sense is on some of these factors is that they stalled or stopped for a period of time, but since has picked back up. Leonard, is that your sense as well?
Yeah, I think a lot of folks or a lot of jails have kind of gone back to their practices of allowing clinicians in the jail. We do see some variants of, arrest eligibility. I mean, it's not exactly written in stone, so it's a little hard for us to kind of put our finger on exactly how the policies have changed. But, when COVID initially hit, a lot of jails really released a lot of folks, and then kind of limited who was arrestable, for lack of a better term. And then some communities have kind of brought those back to normal levels as we've kind of figured out COVID protocols. We know it's safe, we know it's not. There's more testing available, there's more vaccines available, et cetera. But some jails are also keeping their populations pretty low, which is exciting to see. So it's, as far as the simple score, I'm not sure it would change the score of the practices that county was able to do. I mean, most of the things that we're scoring kind of work in and out of the pandemic equally, but in terms of like the outcome numbers that we're looking at, like how many people are entering the jail with showing signs of serious mental illness and how much you're able to connect with treatment. I mean, that's a pretty good case that those numbers are going to look different in a COVID era. So it's a tricky question for us to try to solve of how do you compare counties to counties, and one was just in COVID. So.
Thank you. The next question is, what other policy tools would you recommend for the successful implementation of these type of programs?
Yeah, policy tools, not exactly my area of expertise, particularly at the state level, but particularly at the county level. I mean, anything that encourages these policies and practices to come into place. So like encouraging we're way better with carrots than we are with sticks as a center, to be honest with you. So anything that can encourage evidence-based screenings in jail, for example, would be one thing. Helping fund co-responder or mobile crisis units to do a little more of this Intercept 0 and 1. I mean, I'm not so good at understanding how the funding flow operates, but we do know better, like where what policies and programs can make a difference at a ground level. So broadly, I would say anything that encourages these simple score points to increase in our counties, I think would result in some good outcomes.
The next question is, would you also encourage peer support programs just as much as AOT?
Yeah, I mean, peer support, there's a lot of exciting things going on in the peer support world, though it's peer support programs in itself is pretty broad. I'd be curious on what exactly we mean by peer support. So like one of our post-overdose response programs, for example, really uses recovery coaches to have those conversations about substance use disorder and kind of can encourage folks, wherever that stage changes. So there's definitely some promising results there, and using peers and volunteers and crisis modules can be good practices too. But if you have kind of thoughts about how that would be measured or what exactly program you're encouraging and why that would have an effect on some of our criminal justice outcomes, we're open to hearing more about that.
And next is, what advice do you have for counties interested in implementing social work and law enforcement partnerships at Intercepts 0 and 2?
0 and 2, that's interesting. So probably the sheriff's office and the community mental health agency in a given county know each other. I mean, there's a good chance that, they both typically operate at a county level, and they probably have a lot of folks in common. So, working to find ways that those kind of two main organizations can work together is pretty important. Because I mean, sheriffs tend to run the jails, and the community mental health agency, tends to have a lot of clients or former clients passing through the jail. So there's a lot of folks in common there. So there's probably some kind of conversation that happens, but figuring out a way to formalize that and really think about, what else we could be doing here. Whether that's, more training for law enforcement, whether that's, getting clinicians to find some response after mental health incidents at Intercept One. I mean, there's all sorts of kind of program ideas that kind of things you could latch onto as a way to get started, but kind of just fostering those conversations that are probably already happening at a county level, but aren't really formalized in any way. I guess that's what I would consider, particularly that Intercept 2, where the initial booking in jails, and then Intercept 0, some of this funding piece. I guess that'd be kind of a broader county, maybe even county commission level conversation.
Yeah, the one thing, oh, sorry, Leonard. The one thing I would add to that is, most of our communities that we partner with come through the Stepping Up initiative, which is an initiative that is signed by county commissioners that really put the diversion of mental health out of the criminal legal system as a priority and a value statement in each community. So I really think a great first step is getting the county commission on board to sign a Stepping Up initiative. And then so much can flow from there, because it's a little bit bigger than the sheriff's office and the community mental health system. And then they can all kind of work together and think through a lot of these practices that they could implement afterwards. But it really kind of sets the goals and the targets and the priorities from the very beginning, that the community can then decide how they want to move forward with.
Okay, and the next question is, I'm sorry, does the scorecard have any sensitivity to staffing changes within the county?
Yeah, so just as simple scorecards can go up, the scores can go up. They can also decline as well. So if you have jail clinicians, for example, that were grant funded and they were going on well, that staffing change, if the clinicians are removed from the jail setting, that we would be sensitive to that too. So one thing I do want to mention is, a lot of counties have been asking us, since we kind of announced this and shared the score results with, across our partners, some have asked for kind of updated scores, which is great and exciting. But we also want to kind of tie those updated scores with what's actually going on in the jail, like what outcomes, like how many people were entering the jail with serious mental illness, length of stay, recidivism, and connections to treatment. So, we do want to, get up-to-date scores wherever we can, but we also want to tie that with the actual data that's going on, just to verify that our scorecard is doing what we think it is, but also B, to kind of check if the county has made some progress or not.
Thank you. Next was, do you have any techniques for convincing entities in the benefits of coordination and continuity of care?
I'll jump in here on this one. So this is a really important question that we've been working with, considering for quite a few years when we were doing the jail diversion programs. And a key part of transitioning in and out of jail is that connection to care back in the community. And in most of our, reports and publications that we've written off this data, we really do look at care coordination and continuity of care once individuals leave the jail. And we do this looking at, for those who have Medicaid insurance as they leave the jail, do we find them engaging in treatment through the Medicaid billing data? And specifically, we look after that year that individuals leave, do they engage at all? But also, what about that 2-week period after someone leaves jail? We know that's a critical time. There's increased risk for overdose, increased risk for suicide. So we really look at how that coordination works. And what we find is that those jails that have discharge planning and do warm handoffs are the key intervention. Is there in-reach services going on between caseworkers in the community and the jail? It's a critical time, and having that connection quickly is what we would hope is going on in most communities. The incentive and the discussion around that, I think, is starts from that increased risk, and how can we get people linked quickly back to their case managers or to new case managers. I don't know, Leonard, if you know more specifically about what has bolstered those programs in our communities, but thinking about, a discussion point it's a critical service that is greatly needed.
Yeah, it can be tricky too. I mean, like if the community mental health agency is the one operating in the jail, for example, they can encourage folks to, connect with their own CMH services in the community. But, a lot of folks that enter the jail might not be eligible for that level of care. I mean, there's like serious mental illness, and then there's a lot of folks that do have some concerns going on, we call mild to moderate, that might not actually qualify for the community services. So it's a real tension there. I mean, they can kind of like, who do you exactly send to? I mean, there's access centers that can do some work. There's some, federally qualified health centers that can provide some services. There's like housing resources, and really encouraging that can be tricky. I mean, at the end of the day, someone, will need to kind of do the legwork on their own, but there are some really good practices that a CMH can do without just kind of passing the buck. Like one data matching software we think is really encouraging is, one CMH was able to merge booking and release data with the CMH active data. So when a CMH client or someone with a client history was booked or released, there's like an automatic notification that went to whoever that case manager was. And so that county really showed really good continuity of care outcomes, really connecting with folks, within the 14 days after that jail release. So there's little practices you can do. I think it's there's a lot you can do, especially if there's CMH engaged. It's admittedly harder if you're trying to work to a bridge to another system for your mental health care.
Okay, I think we have time for one more. So the last question is, any ideas on what contributed to the counties that had large simple scorecard changes between 2017 and 2019?
Yeah, contributed to the changes. I mean, those particular counties, I mean, one of them increased their score by 3 and the other increased their score by 2, just huge changes. I mean, really, they had solid champions in place. They, really saw it as a central issue that they devoted a lot of time and energy to. And so, with that kind of mindset and willingness and leadership from the top level, I mean, they really encouraged a number of different things. A lot of it at Intercept One. So, getting that referral system in place, getting that coding system in place, were a couple of those kind of common points among those really progressive counties that push the needle and really improve their outcomes. So, encouraging those activities at Intercept 0 and 1, and then really driving that from the leadership level, we thought was pretty successful.
Thank you, Leonard. We did have a couple of questions that we didn't get through today, so we will compile those and provide some answers and then distribute those back out to the larger group within about a week or so, I would anticipate. So just to wrap things up, I'd like to introduce our director of the CBHJ, Dr. Brad Ray, for some closing remarks. But before that, I'd like to introduce him. So Dr. Ray joined Wayne State University School of Social Work as an associate professor and director of the Center for Behavioral Health and Justice in 2019. He received his PhD in sociology from North Carolina State University in 2012 and served as research director at the Indiana University Public Policy Institute for 7 years. He is a community engaged researcher who focuses on mental health and substance use disorder, particularly where those populations intersect with the criminal legal system. Much of his recent research has focused on evaluating policies and interventions aimed at the recent overdose epidemic and translating evidence-based strategies into practice. Brad.
Thanks, Ronnie.
Mm-hmm.
So I want to thank everyone for joining us here today, especially our presenters and our panelists. And I want to close out this event by giving you all a little bit of a behind the scenes in our day-to-day meetings at the Center for Behavioral Health and Justice. So we have partnerships with stakeholders across numerous sectors, from public safety, the entire criminal legal spectrum, public health, treatment and recovery supports across state and local governments. And we take these partnerships with our community stakeholders very seriously. And to those of you that work with us on a regular basis, it probably feels like we're often reaching out, asking for data to help us understand data. Please complete this survey. Could we get a letter of support? But I want to let you all know that on our day-to-day meetings, more often than not, we check ourselves and we don't put those requests out. And the reason is because, we want to hold off on getting the information until we think it's absolutely necessary, until we're required to do so, but also we don't want to tax the partnerships that we have. We want to maintain them for as long as we can. When a project ends, we want to find a new project with that county. We want to find new initiatives to get involved with. And sometimes we want to keep collecting data even when the projects aren't going. And if you're wondering why do we want to stay in the game with these counties for so long? It's because that we know with more time, with more information, we can create things like the simple scorecard. And this simple scorecard is the exact way that we want to be bringing data to action and informing policy in Michigan. Over the past 5 years, Dr. Comartin, Liz Tillander, and Dean Kubiak have worked to expand these efforts to 24 counties in Michigan. And I can tell you that we're really excited to move into new counties, to collect information there, to continue the partnerships we have with the counties that we're in now, and to share some of the information, some of the findings that we have with new counties from these early adopters. In my opinion, what Dr. Comartin and Leonard have done with the simple scorecard is really take the sequential intercept model to the next level. And I know a lot of you on here know the sequential intercept model really well. You've been trained in it. Probably some of you are trainers in this model. But I also know some of you have probably never heard of this conceptual model until today. So just as a bit of a reminder, refresher, it was developed to inform community-based responses to mental health and substance use disorders in the criminal justice system. Developed in the early 2000s by Henry Stedman and his group out of the Policy Research Associates, I often describe it as off-ramps from the justice system. But the reason that the sequential intercept model is so brilliant is it's one of those things that once you learn it, it reshapes how you see this social problem. It provides everybody with a shared vision and understanding of the problem, right? That this system was not designed to treat this population. And that's why we're trying to route people out of it. And that it often can introduce additional harms when we don't. The sequential intercept model, it also provides us with a shared vernacular, right? Which is key to any real long-term systems change. And I've been in these trainings where you see folks from multiple agencies getting trained in the sequential intercept model, people from police and courts and corrections getting trained. And there's this cognitive shift that occurs where they start to see themselves not just as part of an agency, but finally as part of a system. And they start to understand why the work that's going on upstream in that system, why it's so important for what happens downstream. And at the Center for Behavioral Health and Justice, the sequential intercept model, it's something that guides us and something that challenges us, because we're often thinking, what are those interventions that we can implement upstream and how do we measure those downstream effects? And the simple scorecard has been the most successful approach at that yet, in my opinion. So please don't hesitate to reach out to us to learn more about the sequential intercept model, the simple scorecard, or any of the work that we're doing here in Michigan or nationally with the Center for Behavioral Health and Justice. Thanks everybody for joining us today.